इसमें लगागा मुझे if you feel that it's not going to कहाँ लगागा मैं so निकल तो नहीं जाए So good morning friends, we all welcome you again to this meeting, and at the outset I'd like to thank Dr. Deepak Govil and his team for this invitation and making this course so useful. You know, all our students from all over Delhi and around, they come and join it. It's really a very good initiative which requires a lot of hard work. So I hope you make use of it and we are able to make the lectures meaningful to you guys. So I'm going to talk on thrombocytopenia and coagulopathy in ICU, a quite a common disorder which we all see day and now. Coagulopathies are common among critically ill patients, and deranged coagulation parameters are seen in 14 to 28% of the patients, and thrombocytopenia is seen in almost 50% of the patient during their stay in the ICU. It is very important that you plan a goal-directed management in a risk adjustment manner at early stage to prevent complications. Thrombocytopenia is defined as platelet counts less than 1.5, and almost 50% of the patients who are in ICU have thrombocytopenia during at the admission or during their stay in the ICU. When 5 to 20% of the patient develop severe thrombocytopenia, that is the count less than 50,000. And the studies have shown that a low platelet count is associated with increased risk of mortality, almost double, 33% versus 16%. And if the thrombocytopenia is prolonged, the mortality is almost 4 times. So let's look at the common causes of coagulopathy. For maintaining hemostasis, it is very important that you maintain temperature more than 34 degrees centigrade, the pH should be more than 7.25 and hypocalcemia more than 1. So if any of these are not there, then this predisposes a patient to coagulopathy. Now coming to the causes of coagulopathy, it can be due to deranged hemostasis. If there is the consumption, as happens in sepsis, DIC, cardiac surgery, the patient is predisposed to coagulopathy. If there is a severe blood loss, whether it's a traumatic, surgical, obstetrics, there is an increased risk of coagulopathy in patient. And also if there is a decreased generation or drugs like vitamin K deficiency, if the patient is on vitamin K antagonist, liver disease, so common, so many of our patients who are admitted in ICU have liver disease, hemophilia and drugs, always look at the drugs like heparin, novel oral anticoagulants, direct thrombin inhibitors, direct NA inhibitor. These all predispose patient to deranged coagulopathy, means derangement in PT, PTT, fibrinogen level. About the platelets, we'll discuss subsequently. Also, hyperfibrinolysis, which is seen in ICU patients, make them more prone to bleeding. It can be end-stage liver disease, leukemias, hemophilia, dysfibrinogenemia, massive trauma, thrombolytic therapy, CPR, or external extracorporeal circuits. So hemostasis first is primary hemostasis, which involves whenever there is a trauma, there is a vasoconstriction and the platelet adhere to the endothelium with the help of von Willebrand factor to form a platelet plug, which is known as primary hemostasis. This is the first response to any injury. Then there is a secondary hemostasis which involves formation of fibrin clot through the various intrinsic and extrinsic pathway. So we all remember our pathway. This is a extrinsic pathway which is told to be the first one to come in action after the injury, and subsequently there is amplification of coagulation with the help of intrinsic pathway. So basically tissue factor with contact with factor 7 causes activation of factor 10. At the same time, the intrinsic pathway also gets activated, which involves factor 9, 11 and 12, which again activate factor 10 to factor 10A in presence of platelet and calcium. This factor A, once activated, it converts prothrombin to thrombin, which converts fibrinogen to fibrin monomer, and then they join together to form a cross-linked fibrin clot. So there is a fibrin clot which is formed. So initially primary hemostasis with the help of platelet convalescent factor, and this is the secondary hemostasis trying to control the bleeding. So how do you approach a critically ill patient with coagulopathy? First, rule out inherited defect or use of antithrombin drugs. So history is very important in all these patients, followed by a thorough clinical examination. Then you see whether the bleeding is general or local. If there is a generalized bleeding, do a PT-PTT and blood count, which should have a platelet counts. Now, if the coagulation is normal but only platelets are low, then it can either be due to reduced production or reduced survival, as in autoimmune mediated platelet defects. We'll come to all the mechanisms through example. I'll try to explain to you. Or there can be increased sequestration, as in hypersplenism. If the platelets are low, immediately you do a peripheral smear to see what is the morphology of the platelet. The large platelets are not counted by the counter in which we run the CBC. So you must examine and see whether there are any large platelets and whether there is any they are getting aggregated in the peripheral smear. So next step, as soon as you see a platelet which is low, do a peripheral smear. And if you see fragmented cells or schistiocyte, then you think of a immunological process causing platelet destruction. Now, if the platelets are normal with low coagulation disorder, low deranged coagulation, deranged PT-PTT, then it can be factor VIII deficiency or liver dysfunction, which is primarily responsible for producing many of the coagulation factors, or it can be DIC. Also, when both are deranged, then you think of DIC, which is a consumptive coagulopathy. We'll discuss in the example. So basically, what test do you do? If you have a bleeding patient, we do a CBC, which includes a platelet, do a peripheral smear, and PT-PTT, fibrinogen, and FDP. These are the basic tests trying to diagnose what is the pathology. Now, recently it's come up that these tests, PT, PTT, platelet, they only tell you how the clot starts to form. But how is the progression of clot formation, that you can assess with the help of viscoelastic testing, which gives you a more global picture of hemostatic function, and it involves measurement of interaction between the humoral coagulation pathway, platelet, monocyte, and fibroblast. So, how do you manage this patient? Optimization of hemostasis to minimize blood loss is most important. The cornerstone of coagulation management are appropriate patient evaluation, including the risk of coagulation versus bleeding. All patients with deranged coagulation do not necessarily only have bleeding. Some of the pathologies, they are also prone to coagulopathy. So you please assess that. Then what is the hemodynamic status of the patient? Try to identify the etiology by a proper workup. Treatment with targeted therapy and blood transfusion only when required. Don't start giving blood for a PT of 1.5. Don't give FFP for a PT of 1.5 for a patient who is not bleeding. So you see whether it is really required. So let's first discuss about thrombocytopenia in ICU. The major reasons are hemodilution. If a patient has got massive bleed or massive fluid resuscitation, or it can be due to decrease. See, first let's talk about decreased platelet production. Okay, production is less, destruction is more, or some immunological disorder or hemodilution. So decreased platelet production, if many of our patients are on chemotherapy, radiotherapy, on cancer, they've got cancer, various viral infections, drugs, storage disorders, not so common, malnutrition, or it can be due to increased platelet destruction, which happens in patients with HIT, ITP, mechanical devices. During COVID era, we saw so many of ECMO patients who were being given ECMO therapy for treatment of ARDS. So these mechanical devices, CRRT is another modality which is so commonly used in the ICU, that makes patient more prone to thrombocytopenia through platelet destruction. Also, it can be increased platelet consumption, as in patients with DIC, TTP, HELLP syndrome. or increased platelet sequestration. A typical example is a CLD with patient who's got hypersplenism due to splenomegaly and also congestive heart failure. There's also a terminology known as pseudothrombocytopenia. That is why I said you must examine peripheral smear to see whether there is any aggregation of platelet which can happen in patients if the sample is collected in EDTA. So you must do a peripheral smear and confirm that it is not there, and this can further be confirmed by doing a platelet count in a citrated blood. Drug list, always go through the drug list on which the patient is on. Antiplatelets, anti-GP2A3 inhibitors, antibiotics, trimethoprim, sulfamethoxazole, beta-lactam, vancomycin, linezolid, anticonvulsive drug like phenytoin, carbamazepine. These days we use, most of the time we use levetiracetam. So that has got very less risk of thrombocytopenia. Or ranitidine also has been shown to, of course we use more of pantoprazole these days, but ranitidine also was shown to reduce platelet count. Now also to know the etiology, if there is presence of dedicated criteria such as positive culture or a clinical picture, then thrombocytopenia is most likely due to sepsis. If there are deranged PT, PTT platelet, DIC is more probably the cause. If there is a massive blood loss, of course from the history you can know that. If there is a schistiocyte in the blood film and the clinical finding, think of TTP. If there is a positive history of heparin use and patient develops some gangrenous changes on the finger, I'll show you the picture, then think of HIT. If there is an immunological disorder, think of immune thrombocytopenia and look at the drugs. Now let's start with this case, a confused 64-year-old male patient presents with history of multiple myeloma who has received a recent chemotherapy. He is admitted to ICU with hectic fever, shivering and circulatory shock. When the patient was examined, there was no infection at the site of chemoport, but there was an infected wound on the hand. The lab showed a CRP of 247, procalcitonin 223. There was AKI, coagulopathy, PT was 16 second, PTT 34 second, platelet counts were only 48,000. So this patient was immediately fluid resuscitated, started on broad spectrum antibiotic, and a debridement was planned after stabilization because the patient was in severe sepsis, septic shock. So what is your diagnosis on this? What is the cause of thrombocytopenia? This is the data. And what will you do? Will you give FFP to this patient? Patient is not actively bleeding, PT-PTT only mildly deranged, you don't need to give. And what must be the most common cause, most probable cause of thrombocytopenia in this patient? I told you the list of sepsis. Absolutely, very good. So sepsis-induced thrombocytopenia accounts for 50% of all thrombocytopenia in the critically ill patient. The mechanism is multifactorial, which involves decreased platelet production, increased consumption, sequestration frequently by the hemophagocytes which are there, and enhanced consumption in forming the platelet clot. So this is a second case, 70-year-old male, known case of diabetes and CAD. He was admitted with chest pain for 3 days, started on medical management because there was no hyperacute changes on the ECG. So we thought that let's stabilize the patient first. So he was given antiplatelet, heparin, statins. NGO was done after 2 days, which showed a triple vessel disease. Hemoglobin was 10, counts were okay, platelets 1.74, creatinine also 1.2, LFT was normal. PT-PTT normal. So because there was a triple vessel disease, he was taken up here, diabetes, he was taken up for CABG. And day 6 post-op, this is what was noticed. So again, I would like to say that please examine your patient thoroughly. Don't just look at the monitor and don't just treat the test. You know, if you do not remove the sheet and examine your patient, you can miss it. So what is this? Yes, very good. Because patient has received heparin, you know, the time window comes in that, and there is no gross evidence of sepsis in him. And here the investigation showed a platelet of almost 55,000, and the D-dimer was raised, fibrinogen was borderline, creatinine bilirubin was normal. So most probably this is a case of HIT. So HIT is a complication of unfractionated therapy usually seen after 5 to 14 days. I'll tell you there are two types of HIT. Type 1 is not that aggressive, but this is the one which is more important. There's formation of antibodies. See, the heparin forms complex with PF4 which acts as an antigen, and there is a generation of IgG antibody against it. There is an antigen antibody complex which goes and attaches to the FC receptor and leads to activation of platelet. This activation of platelet leads to further release of coagulation factors and generation of more PF4. So the patient enters into a vicious cycle. So there is a formation of antibodies that activate platelet following heparin administration. I told you the major antigen is PF4 heparin complex, and suspected in a patient of heparin who is on heparin for 5 to 14 days and unexplained thrombocytopenia. It's more common with unfractionated heparin, but it's less with low molecular weight, but it's not that it does not happen with that, except for maybe fondaparinix. So there is a 4T score which you must remember and you calculate, which includes thrombocytopenia, timing of platelet drop, thrombosis and other causes of thrombocytopenia to be ruled out. And then you look at the score, and if the score is 6 to 8, there is a high probability. As I was telling you, there are two types of HIT 1 and HIT 2. HIT 1 is usually a mild form which happens early, within 1 to 4 days. And the platelet decrease is only mild. Usually it is more than 1 lakh. The incidence is high, but it is self-limiting if you stop heparin, sorry. And the HIT 2 I told you, this is a severe form which happens 5 to 14 days after exposure to heparin. And here the platelet counts are usually less than 1 lakh. There is 30 to 50% drop in platelet count. The incidence is less, but it is more lethal. So please examine your patient. It can cause MI, it can cause stroke, you may require amputation of your extremities if it goes unnoticed. So this is a flow chart which says that if you suspect a HIT, calculate 4T score. If the score is 4, then 3 or less, then practically you can rule out HIT. If the score is 4 and more, discontinue heparin and you obtain immunoassay. If it is positive, continue to avoid heparin and do a confirmatory test like serotonin assay. If that is positive, then HIT is the most probable cause. Otherwise, if it is negative, then you examine clinically, and better to avoid heparin even in this situation. And the treatment is intravenous direct thrombin inhibitors. Bivalirudin is available these days. And how long do you give anticoagulation? If there is no evidence of thrombosis for 4 weeks, that is 1 month. If there is evidence of thrombosis for 3 months. Now this is an 18-year-old female, had a fall, admitted with polytrauma. There is a subarachnoid hemorrhage, bilateral hemopneumothorax and pelvic fracture. Patient was on hemorrhagic shock. So during the transport, patient received fluid resuscitation. On admission, hemoglobin was 6. There was a coagulopathy with a platelet INR of 1.3, PTT 48, platelet counts were coming down 1.45, and the CT showed a retroperitoneal bleeding and ruptured pelvic vessel. So what will you do? What will someone can tell me? Yeah, anyone? Yeah, you'll start the fluid resuscitation, arrange blood product, massive transfusion protocol. What else? Urgent surgical and radiological opinion should be taken, because these patients, along with correcting the coagulopathy, you need to control the bleeding. Okay, so you ask your radiological friend, you ask your surgeons to be around, tell them that we are going to do imaging, and then this patient may require maybe initially embolization or a surgery also. Okay, so activate that system. So what is the definition of massive transfusion? Massive transfusion, they say, ideally patient requires more than 10 units of blood in 24 hours. But that's quite a long time, isn't it? You can't wait for 24 hours to label a patient as a requirement for massive transfusion. So there's another definition which says that if a patient requires more than 5 blood PRCs in 4 hours, then again this is labeled as massive transfusion. And here you have to give PRC, FFP and platelet in a ratio of 1:1:1. Okay? Moreover, in cases of trauma, there's a crash 2 trial which says there's a definite role of tranexamic acid, and earlier you give, less is the mortality. Preferably give 1 gram within 3 hours and another 1 gram over 8 hours. This is shown to be definitely beneficial in this group of patients. So always remember this. ITP, usually the patient doesn't present to ICU, but they could be having a IT or a chronic ITP and then they come. Here again, the treatment is not just giving platelet, treatment is giving IV, IG and steroids. If a patient is bleeding actively, of course you give, otherwise IV, IG and steroids. And in refractory cases, if there is no infection, you can give rituximab and subsequently splenectomy. This is the usual it's a autoimmune disorder characterized by low platelet, purpura and hemorrhagic episodes due to antiplatelet antibodies. So this is a question maybe, as I told you, when do you worry about coagulopathy in patients who have got thrombocytopenia? I showed you one example which was HIT, okay? All this immunological disorder, you have to be always careful about coagulopathy. So do not give indiscriminately platelet transfusion. You have to justify why you are giving. Don't treat numbers, treat the patient. Unless the patient has to go for surgery or actively bleeding. So HIT, thrombotic thrombocytopenia purpura, DIC, vaccination-induced thrombocytopenia, COVID vaccination, all of us know AstraZeneca. They saw some patients did have vaccination-induced thrombocytopenia and antiphospholipid antibody. So these things always be seen, and especially when you are thinking of these, watch out for that and limit your platelet transfusion unless absolutely required. So this is a 60-year-old patient presented 3 days after abdominal surgery with breathlessness. He's got fever, he's hypotensive, there's tachycardia, tachypnea, there's hypoxia, saturation is 84, And the lab value shows 19,000 TLC, neutrophilic predominance and some schistiocytes. Creatinine is 2.4, bilirubin 1.2, lactate 3.3 and bicarbonate of 18. So patient was intubated, ventilated, fluid resuscitation, noradrenaline started, broad spectrum antibiotic initiated, subcutaneous heparin prophylaxis started, and the coagulation parameters which came as platelet 98,000, PT 20 with a control of 11, INR 1.6, PTT 48, fibrinogen 150, D-dimer 7.5. So what is this? Huh? Very good. DIC, right? You have got a sepsis in the background. DIC is usually secondary, it's not a diagnosis by itself, it's usually secondary to some insult. Okay? D-dimer is, you have to look at the DIC score, right? So, can it be sepsis-induced thrombocytopenia? The PT, PTT and all that is significantly deranged, right? So, it's unlikely. It's not only thrombocytopenia, there is a set of coagulopathy also. I told you thrombocytopenia, coagulopathy, there are 2 parts of coagulation disorder. TTP, normally PT-PTT is normal in these patients, right? Which is not here. D-dimer can be raised because they are forming clots, but PT-PTT is normally raised. Some schistiocyte which we saw enough this thing, peripheral smear, can also be seen in DIC. So unless there is significant fragmentation, DIC also you can get schistiocyte. Then heparin-induced thrombocytopenia, of course no, because PT-PTT everything is deranged. So the thing which remains is disseminated intravascular coagulation. One of the very common disorders we see in critically ill patients. So as I told you, DIC is usually secondary to some insult like a severe infection, malignancy, trauma, obstetrical complication, severe immunological reaction, heat stroke and post-CPR. It is seen that heat stroke and post-CPR mainly they have coagulopathy rather than bleeding. So you have to, that's why you have to come to a diagnosis so that you can plan your therapy accordingly. So the pathogenesis of DIC disseminated intravascular coagulation. So there is a consumptive coagulopathy and there is also thrombosis. So there is activation of intravascular coagulation after the insult which causes platelet consumption causing thrombocytopenia, coagulation factor consumption causing increased PT-PTT and fibrinolysis which causes increased D-dimer. All this predisposes patient to bleeding. Also, there is a endothelial damage which causes microvascular thrombosis responsible for multi-organ failure. So there is a DIC score which includes platelet, level of fibrin markers, prolonged PTT and prolonged prothrombin time and fibrinogen level, and then you score it. So this is a therapeutic approach. If there is a clinical suspicion and there is low PTT platelet, use DIC scoring. If it is less than 5, DIC is ruled out. Look for other cause. If it is 5 or more, then treat the underlying condition. All DIC doesn't mean you start giving blood. If there is no major bleeding, just give low molecular weight heparin to these patients. If there is active bleeding, then you must give platelet transfusion, trying to correct your platelet count to 30 to 50,000. Patient is bleeding actively, then you try to correct PT, they say less than 3 seconds above normal, and try to give fibrinogen to maintain fibrinogen more than 1.5 gram per liter. Vitamin K antagonist, though not proven role, but they say yeah, if you suspect a vitamin K deficiency, it can be given. However, if there are overt thromboembolic signs, then you should give therapeutic anticoagulation and not heparin. Antithrombin concentrate, these are some experimental therapy, showed that there is improvement in lab values and organ function but no mortality benefit. Activated protein C came in a big way maybe about 10 to 15 years before, it came by the name of Zygris. We used it in multiple patients, but subsequently there was a DIC trial which said that it does not help, so it was withdrawn from the market. A promising intervention that is currently being evaluated is recombinant soluble thrombomodulin. Almost phase 3 trial is over and it is showing a significant mortality benefit. All these trials are mainly going on in Japan, so maybe in next 2 years or so we may have some treatment for DIC because DIC is associated with very high mortality. Now this is a 55-year-old male presents with history of fever, loose stool 6 days back. Now presents with altered sensorium, oliguria and a palpable purpura. This is how his hand was. Large palpable purpura. He was febrile 101, BP was okay, saturation 94%, hemoglobin was only 8 gram, there was a leukocytosis, platelet counts 40,000, PT-PTT was normal, creatinine was deranged, bilirubin was high, but majorly it was an unconjugated hyperbilirubinemia. So what will be your diagnosis on this? Sepsis of course remains your first possibility, so you work out for that. Otherwise, because there was a history of loose stools and now there is a neurological symptom, oliguria, thrombocytopenia and indirect bilirubinemia, then what will you do next? Yes, you do a peripheral smear and look for schistocyte, right? Irregularly this thing, okay? TTP also can have fever. It's a pentad. I know all of you know it. Okay. It can have fever and usually in TTP the counts are high. So very easily you can get confused with sepsis. So that is why of course I will give a broad spectrum antibiotic to this patient. But then this also will be my diagnosis and then I'll see how the patient progresses. And then there is a plasmic score for TTP which you can use. Okay. And if the score is 7, then it's a high probability of TTP. And because TTP is again a medical emergency, you cannot sit on it. If you do not treat it, patient will develop organ failure which may not become reversible. So it's very important that you suspect it and you treat it. So evaluate t-test possibility of TTP, the clinical presentation, the examination and the plasmic score, and based on clinical judgment and plasmic score, if the probability is high, start therapeutic plasma exchange almost 1.5 times the plasma volume immediately plus steroids, and if possible you do a ADMATS 13 activity. Most of the places ADMATS 13 is not available. So here you continue with therapeutic plasma exchange, and normally you take 3 to 5 sittings of plasma exchange for the effect to be evident. Don't think that one platelet you've done today, tomorrow the platelet counts are not responding, does not mean that the patient is not responding. Okay? And if you can do ADMATS 13, then there's another option which is Ceftazidimab, which can be given if you prove that it is TTP. But only give this if you are able to measure ADMATS 13 level, because after the report comes you can stop it. If it is not possible, then just therapeutic plasma exchange. We routinely do therapeutic plasma exchange and steroid, and the patients do improve if used in time. Also, one thing which I like to tell you is, if you are giving a low molecular weight heparin to your patients and the patient develops, something which suggests that it could be pulmonary embolism, don't think that it can't be pulmonary embolism. Giving DVT prophylaxis reduces the risk, but it still not make the patient free of pulmonary embolism. So always look at that if there is a clinical suspicion. The PODA prediction score, which is used in admitted patients, this was used for assessment of VT risk in admitted patient, does not hold true in critically ill patient. There is another score which is ICU venous thromboembolism score, which you should use if there is a suspicion of VT in your patients. So always along with coagulation, there are some conditions which increase the risk of bleeding, which is common, I would say, is hepatic and renal dysfunction, renal replacement therapy, concomitant anticoagulation medications, and the antibiotics and heparin. So always look out for that. Couple of slides, just 5 minutes. Now liver, so many of our patients are admitted with liver disease, right? I think at least 20-30% of the population has a CLD or has liver involvement. So what is the mechanism of coagulopathy in this patient? Most of the hemostatic proteins are synthesized in liver. There is decreased synthesis of coagulation factor in patients with liver disease. Also there is reduced production of physiological anticoagulant like protein C and protein S. So they have a risk of bleeding as well as thrombosis. And here viscoelastic test, TEG, which is, if possible, you should use that. That is shown to have more prediction of which blood product to give if they are bleeding. There is no role of prophylactic FFP. PT-INR 1.6, we want to put a central line, we ask for 4 FFPs. No, that is not what should be done. Unless the patient has got bleeding tendencies, bleeding actively, or the PT is really high, you can put a central line under ultrasound guidance. Okay? If a patient is bleeding with liver dysfunction, plasma should be given to reduce prothrombin time to less than 2 times and give adequate plasma. FFP1-BD, FFP1-TDS has got no role. You give 15 to 20 ml if possible. If a patient is fluid overloaded, you can also use factors. Maintain fibrinogen more than 100. Some say 60, but 100 is a safe limit, and platelet count more than 50,000 if a patient is bleeding in patient with liver dysfunction. Again, CKD, so many of our patients are admitted with CKD in ICU. They also have a higher risk of bleeding because there is accumulation of uremic toxin which result in platelet dysfunction. The count may be 80,000, 90,000, but the quality of platelet is not good because the function has been deranged because of uremic toxins. Typically, these patients present with ecchymosis, purpura, epistaxis and bleeding from the puncture site. And the treatment here, the most important treatment is dialysis. But if the patient is not that unstable, you can also try cryoprecipitate, which you give again adequate unit, not too cryo, 10 units over 30 minutes. Desmopressin, unfortunately, I could not find intravenous injectable preparation, so we give nasal spray. but otherwise the recommended is 0.3 microgram per kg. And conjugated estrogen, again we're not able to get this because we did do research for this. Many of our uremic patients bleed, but this is what is recommended. And this is supposed to have maximum duration of action. So by then I'm sure your patient will stabilize. So if you give it for 5 days, you have a time window of 14 days. So this helps in reducing the bleeding and subsequently the blood products requirement. I told you many of these, especially in ECMO, this COVID era, we did so many ECMO, and these patients again had a risk of coagulation disorders. So if a patient is bleeding, only then you should give FFPs, and you can also give PCC, which can platelet prothrombin complex concentrate, which comes as PCC3 and PCC4. 3 has got factor 2, 9 and 10, and 4 also has factor 7. On average, the concentration of coagulation factor is 25 times. So the risk of volume overload, I just show you one slide which says advantage of plasma versus this concentrate. However, PCC does not contain fibrinogen, so you may have to still give fibrinogen concentrate, that is cryo concentrate, and sometimes even FFP, but the volume of that will be much lesser. So this I think can always do. So blood products and factor concentrate. Blood product typically FFP, which contains all the factors including von Willebrand factor and factor 13, but the amount is very less concentration, so you have to give a large volume. It's been studied well, especially in massive transfusion protocol, because their volume substitution is also an important consideration, and it is relatively cheap. Disadvantages: it's got low concentration, transfusion related infection, risk factors, requires cross matching, large fluid overload, risk of volume overload, and thawing takes time. FFP thawing takes somewhere between 60 to 90 minutes. So if a patient requires immediately, it may not be available. The factor concentrate, the advantages is got high concentration of the factors, few complications which are related to the transfusions, no cross matching required, and you require to give small volume. However, the disadvantage I told you, it does not have fibrinogen factor 12, so you may still have to give blood products. Cost is very high and it requires parallel fluid resuscitation if a patient is hypovolemic. So this is what I was talking to you about, point of care coagulation monitoring system, which is basically TEG, ROTEM and SonoClot. So if available, it gives you the way the clot is formed. There are various angles, the width which you look at, and it also gives you the value and tells you which product is required. So this is recommended in an actively bleeding patient, especially in liver dysfunction. So if you have a facility, you should use it in an actively bleeding patient. You can also reduce the amount of blood transfusion with this. So coagulopathy is a condition in which blood's ability to clot is impaired. It's very important that you take a proper medical history and try to make the diagnosis. Don't just give blood product indiscriminately. A peripheral smear, whenever there is a thrombocytopenia, always examine peripheral smear for any toxic granules, any premature cells. Avoid correction of laboratory abnormality with blood product unless there is a clinical bleeding or surgical procedure is required. Tranexamic acid, I told you, should be given in patient with trauma. No supportive evidence of prophylactic use of FFP to correct abnormal result before an invasive procedure. Despite the lack of high quality evidence, vitamin K has been recommended in these bleeding patients. The cornerstone of managing DIC is manage the cause. A platelet transfusion of 10,000 per cubic millimeter for stable patient. They say 20 to 30,000 if you are planning to put a line, 50,000 for minor surgeries and more than 1 lakh especially for the neurosurgical procedures. Fibrinolytic bleeding should be considered particularly in patients with liver disease and disseminated cancer. Studies that have evaluated the reversal of new anticoagulant have been limited to reversal of drug effect with the use of recombinant factor 7 and prothrombin complex concentrate. Also, you have got a antidote for dabigatran, italisumab. That is available. So if you are using an anticoagulation, that is the one comfort of using dabigatran, because you have got an anticoagulant. So in case your patient bleeds, you can give that to control the bleeding. Thank you. Any questions?